think there's some messaging on, particularly with fitness influencers, it seems that, all women just need to throw their birth control in the trash, do things naturally. And I think that has the potential to cause some harm. So now let's get into some controversy with oral contraceptives specifically. So are PCOS patients being helped by being put on oral contraceptives? Are they extending their reproductive window? And we can get into a bit of nuance, like what are the other factors here? But just to kind of start that discussion, they have their place, but what are the patients that would be a high yield intervention for? What are the patients that may be best managed in other ways?
Patients that want symptoms addressed right away that also are needing of contraception are wonderful candidates of oral contraceptives because it's a two birds with one stone. And of course, again, it's a continuum or spectrum, and there's patients anywhere in between where they're a fantastic candidate for a oral contraceptive or a terrible candidate of an oral contraceptive. If they desire fertility soon, then they're not a very good candidate of an oral contraceptive, not just because it is a contraceptive, and by soon I mean within about 12 months, but also because there can be a lag in returning to baseline of normal cycles, the timing and also the ovulation of the cycle, and there can also be a lag in returning to a normal hormone profile.
Absolutely. And then I think there's some messaging on, particularly with fitness influencers, it seems that, all women just need to throw their birth control in the trash, do things naturally. And I think that has the potential to cause some harm in a condition like endometriosis, where you are intentionally wanting to suppress estradiol to extend that reproductive window. Yep. So I think that's just something that people should be aware of. So hopefully that information is helpful to some people.
Absolutely.
And when we get into fertility, so let's say you've gotten off your oral contraceptive, you have gotten your metabolic symptoms addressed, you're more insulin sensitive, let's say you had a 10% weight loss and now you're ready to conceive, you're healthy, your partner's healthy. What are some of the treatments that we would use if somebody doesn't conceive naturally, or it's been, let's say, 12 months of trying and we haven't seen conception?
Mm-hmm. A lot of the supplements and medications we already mentioned are also fertility meds. Many people get in a combination of the myo-inositol and D-chiroinositol. Many people also take metformin. In general, the higher the body fat percentage and BMI, the more helpful metformin is. Aromatase inhibitors and SERMs. Aromatase inhibitors, by the way, they're medications that inhibit the conversion of testosterone to estrogen. Those are often used between about day 3 and 8 of the cycle. And SERMs, which are selective estrogen receptor modifiers, they can block estrogen in specific tissues. For example, the hypothalamus and the pituitary, where the precursor hormones called gonadotropins are made to stimulate the ovaries. Often those are also used during the same period of time. Each has different side effects and such, for example, ocular side effects, but in general, both of those treatments will increase the chance of a multiple gestation.
Right, and that's when we see a lot of times the news stories where someone had 5 or 6 children at once. A lot of times there are fertility drugs that are involved there, and you have multiple gestation, which comes with its own set of risks as well to the mother's health.
A good rule of thumb is that when you're starting a medication like letrozole or Femara is one of the commonly used aromatase inhibitors, and for individuals who need it, I do prefer it over clomiphene or Clomid. When you use it from days 3 to 8, you want to start with a very low dose, for example, 2.5 milligrams, and very slowly titrate your way up, likely using the lowest dose for at least a few cycles before titrating up to a higher dose to decrease your chance of multiple gestation. Aromatase inhibitors also have much lower risk of multiple gestation than SERMs, like Clomid.
Yeah, I think that's a great way to look at it, and more isn't always better. In general, starting low and working your way up is a great approach.